Together for a future with health for all, hunger for none.
Okay, can you hear me?
My journey continues, and I know I'm not alone. Because together we can make a difference every day.
Okay, good afternoon, all the colleagues. We are pleased to welcome everyone here in this session. This afternoon, we continue the first day of the 14th Congress of ASCI in Scientific Section 2 about the cardiac MRI. I am Dr. Nguyễn Khôi Việt, Chief of Cardiovascular Imaging in Radiology Center, Hanoi, Vietnam. I would like to introduce the co-chairperson of the delegation in this session, Dr. Zakus Pandelakis from Indonesia. Please welcome.
Good afternoon.
Okay. In this section, we have 9 topics with a speaker from Japan, Indonesia, China, Korea, and Vietnam. In order for the conference session to begin, I would like to invite Dr. Akio Inage from Japan. He's a pediatric cardiology with topic native hepatic T1 may be a potential marker for liver fibrosis in full-time patients. Please. Dr. Akio Inage, please.
Yeah, I'm here. Yeah. Okay. Let's start the slide.
Survival patient single ventricle congenital heart disease. Hemodynamic changes associated with the frontal circulation including elevated central venous pressure and diminished cardiac output, are responsible for the development of Fontan-associated liver disease. Liver fibrosis is a universal feature following the Fontan operation. The incidence of both liver cirrhosis and hepatocellular carcinoma increases with the duration of the Fontan circulation. Patients with failing Fontan circulation who have evidence of significant hepatic congestion require careful hemodynamic assessment to optimize the Fontan pathway and physiology. Liver hardness can be measured by MR elastography, but it was not common due to the additional application required for imaging. There is a lack of development of reliable, non-invasive monitoring technology. In recent years, research and reports using T1 mapping have been actively carried out, and the Sakakibara Heart Institute has been working on it since 2019. There are two types of T1 mapping, non-contrast native T1 mapping and extracellular volume using a contrast media. At our hospital, we use non-contrast native T1 map. Native T1 mapping has been reported to increase T1 levels due to fibrosis, edema, amyloidosis, and decreased T1 levels due to dyslipidemia such as Fabry disease and iron disposition. We hypothesized that native hepatic T1 could also be quantified in patients with Fontan variation and provide a means of assessing liver health. The objective of this study was to evaluate using native T1 mapping for diagnosis and grading of liver fibrosis in patients with Fontan variation. It's a methodology. Fontan patients in Group A prospectively underwent cardiovascular MRI, including native T1 mapping of the myocardium in a single short axis plane. A portion of liver was counted to quantify T1. Hepatic native T1 was measured between comparison groups with heterologous Faro patients in Group B and healthy control in Group C who had previously undergone CMR. In Group A to C, hepatic T1 was randomly measured in 8 liver parenchymal tissues in the liver T1 image. At the same time, myocardial T1 was measured, and the rate of change from myocardial T1 to hepatic T1 was calculated. In Group A, correlation between hepatic T1 and gamma GTP, total bilirubin, M2-bPGI, hyaluronic acid, total bile acid, type 4 collagen, total protein, central venous pressure, pulmonary artery pressure, ventricular end diastolic pressure, stroke volume, ejection fraction, cardiac index, and the postoperative period were examined. The MRI machine is a GMS magneton solar 1.5 Tesla. I will show you the result. Patient background for Group A, Fontan group. There are 4 cases of right ventricle, 2 cases of left ventricle, and 4 cases of Fontan circulation with both ventricles. The surgical procedure was extracardiac total cardiopulmonary connection TCPC in 7 cases, of which 3 cases had fenestration. The remaining 2 cases were lateral tunnel TCPC and atriopulmonary APC Fontan. The postoperative period of Fontan was 1 to 27 years. Patient background for Group B, tetralogy Faro group. 7 cases were repaired tetralogy Faro. The remaining 3 cases were repaired pulmonary stenosis, repaired truncus arteriosus, and repaired the complete transposition of the great arteries. The mean age of Fontan Group A was 27 years. There was no significant difference in native myocardial T1 between Group A to B. Native hepatic T1 in Group A was significantly higher than in Groups B and C. Similarly, the hepatic T1 myocardial T1 ratio in group A was significantly higher than in groups B and C. The correlation with each parameter in group A looks like a slide. Native hepatic T1 strongly correlated with hepatic T1 myocardial T1 ratio. Hepatic T1 myocardial T1 ratio correlated with liver fibrosis marker. Hepatic T1 myocardial T1 ratio correlated with ventricular ejection fraction in Fontan patient. The longer the Fontan circulation, hepatic T1 tended to be higher. There was no correlation between native hepatic T1 and hepatic congestion fibrosis marker. However, there was a correlation between hepatic T1 myocardial T1 ratio and total bilirubin, M2-BPGI, hyaluronic acid, and type 4 collagen. A correlation tendency was observed between native hepatic T1 and hepatic T1 myocardial T1 ratio and ejection fraction, and between hepatic T1 myocardial T1 ratio and cardiac index. There was also a correlation between native hepatic T1 and the postoperative period of Fontan, suggesting that the longer the Fontan circulation, the higher the native hepatic T1. In conclusion, native hepatic T1 can be measured and is significantly higher in Fontan patients compared to tetralogy Fallot patient and normal control. Hepatic T1 myocardial T1 ratio seemed to be useful for determining the progress of liver fibrosis. Hepatic T1 may be an alternative method of following fibrosis burden, though its significance requires further study. Thank you for your attention.
Comment from the audience? Okay, before time strictly, we can move the question and answer in the end of section.
Okay.
So next topic, please, Dr. Pandelakis. Yujan.
Yeah, thank you, Dr. Nguyen. So the next speaker is Dr. Octavia Liliasari from Indonesia. The topic is the role of cardiac magnetic resonance imaging. May I show the screen share? Yeah, can you see my share screen? But blank, yeah? I don't know.
Blank. We cannot see.
Okay, only the picture. Okay, yes. The role of cardiac magnetic resonance imaging in congenital heart disease. Single center experience. Dr. Octavia Liliasari, please present.
Greetings everybody. Thank you for this opportunity. My name is Octavia Liliasari, representing the Department of Cardiology and Vascular Medicine, Faculty of Medicine, Universitas Indonesia. Today, I would like to present a study entitled The Role of Cardiac Magnetic Resonance Imaging in Congenital Heart Disease, Single Center Experience. As an introduction, throughout the years, we have encountered various significant advances in the field of magnetic resonance imaging, especially in terms of cardiac application. Due to its advances, surely it didn't come as a surprise that recently cardiac magnetic resonance imaging has emerged as an accurate method for evaluation of the structure and function of the heart. In line with its evolving nature, in Indonesia, cardiac MRI is now considered as a crucial non-invasive imaging modality for congenital heart disease. Furthermore, it is also now established as a new adjunctive technique at our center, alongside with echocardiography and cardiac catheterization. In this presentation, I would like to present our study, which is aimed to review the clinical indication of cardiac MRI in patients with congenital heart disease at a tertiary center in Indonesia. At our center, the cardiac MRI examination was performed using the Philips Medical System 1.5 Tesla scanner. Similar acquisition protocol were used in all of the patients, which includes the EKG-gated sinus steady-state free precision, velocity encoded phase contrast for quantitative blood flow measurement. Quantitative assessment of ventricular volume and function were performed with EKG-gated breath-holding short-axis sinus steady-state free precision with 6 mm slice thickness. Lead gadolinium enhancement and T2 weighted stir was used for tissue characterization. And administration of gadolinium contrast agent was performed for angiographic evaluation. Post-processing analysis was done with dedicated Philips workstation and CVI-42. Our study was conducted from January 2013 up until July 2019. A total of 1,420 congenital heart disease patients was found throughout this period. This is the baseline demographic of our study. Most of the patients were female, with percentage of 61.06%. The median weight of our patient was 44 kilograms, with the minimum weight of 10.8 kilograms and the maximum weight of 104 kilograms. The median age of our patient was 213 months, with the minimum of age 19 months and the maximum of age 1,414 months. Then we divided the age into 3 categories, and we found that 11.7 patients with the age less than 10 years old, 39.3% in the range of 10 up to 18 years old, and 49.1% more than 18 years old. From our observation, there were several indications inquiring our patient to underwent the cardiac MRI examination. Those indications include characterization of anatomy and morphology, measurement of flow ratio, quantification of volume and function, tissue characterization, and evaluation of thrombus formation. There were several pitfalls encountered throughout our experience with the cardiac MRI examination, which include technical difficulties, such as arrhythmia, uncooperative patient, inability of breath-holding command, and the lack of anesthesia facility. Beside the short-axis EKG-gated sinus steady-state free precision sequence for function evaluation purposes, all the sequences were performed with free breathing and no sedation. These were the clinical indication for patients with requiring cardiac MRI examination in our center. As you can see, atrial septal defect was observed as the most common clinical indication, with the percentage 15.92%, followed by patient with tetralogy of Fallot or pulmonary atresia with ventricular septal defect. Other clinical indications for cardiac MRI in our center include VSD, myocarditis, absent anomaly, pulmonary regurgitation, double chamber right ventricle, patent ductus arteriosus, double outlet right ventricle, and valvular pulmonary stenosis. Other than that, several post-operative conditions also emerged as the clinical indication for the cardiac MRI examination, which include the tetralogy of valve repair, BCPS procedure, Fontan procedure, valvular repair, Rastelli procedure, and BT shunt. Throughout our observation, there were several things that we could conclude. The first one, the use of cardiac MRI in patients with congenital heart disease depends on age, clinical condition, and diagnostic purposes. The second one, our experience showed that inability to breath-holding command, lack of patient cooperation, lack of anesthesia facilities were the reason cardiac MRI can only be done in older children, adolescent, or even adult in our center. And that marks the end of my presentation. I hope that my presentation could give useful insight for other center. Thank you for your attention and stay safe.
Thank you, Dr. Octavia Lilasari. Okay, as Dr. Nguyen mentioned, maybe question will be in the end of this session, Dr. Nguyen. So please, Dr. Nguyen, for the next speaker.
Okay, thank you for the nice presentation. Up next, I would like to invite next speaker, Dr. Yan Nhan Song. She is a radiologist from Fuwai Hospital, National Center for Cardiovascular Disease, China, with topic early left ventricular diastolic dysfunction and abnormal left ventricular left atrial coupling in asymptomatic patients with hypertension, a CMR feature tracking study. Please, Dr. Yan Nhan Song.
Good afternoon, ladies and gentlemen. My name is Yan Song from Department of Radiology for Hospital. It's my great honor here to introduce my recent research about early left ventricular diastolic dysfunction and abnormal left ventricular left atrial coupling in patients with hypertension. This is a cardiovascular magnetic resonance feature tracking study. Patients with chronic or poorly controlled hypertension have an increased risk of left ventricular hypertrophy and left ventricular diastolic dysfunction. Early detection of left ventricular diastolic dysfunction before left ventricular hypertrophy may assist to reverse cardiac abnormalities by providing timely and preventive treatment for hypertension patients. In addition, as the left atrium is directly exposed to the left ventricle during diastolic, left atrium may also provide information on subclinical left ventricular impairment for the overall chronic left ventricular pressure. Cardiovascular magnetic resonance feature tracking could be applied in the detection of subclinical myocardial changes. So our aim was to evaluate whether CMR feature tracking is a promising method to detect early left ventricular diastolic dysfunction and to evaluate LV, LA coloration in hypertension patients. A total of 110 hypertension patients were retrospectively enrolled into this study. 21 of the 110 patients were excluded. The residual 80 69 hypertension patients were finally enrolled and further divided into two subgroups. The left ventral longitudinal strain and strain rate were obtained by checking the long horizontal axis thickness, whereas the circumferential radial strain and strain rate were derived from the short axis thickness. LA endocardial border was manually traced at the phase of maximal and minimal LA volume in both the two-chamber and four-chamber CNA images. The clinical characteristics and the conventional CMR data were summarized in this table. Compared with controls, the conventional CMR parameters were significantly increased in hypertension patients with left ventricle hypertrophy, where there were no statistical differences between hypertension patients without left ventricle hypertrophy and controls. As shown in this table, compared with controls, the left ventricle peak diastolic strain rate in radial, circumferential, and longitudinal directions and the LA reservoir and conduit function was significantly impaired in hypertension patients regardless of left ventricle hypertrophy. In this figure, we can find that compared with controls, hypertension patients with or without left ventricle hypertrophy had significantly impaired left ventricle peak diastolic strain rate in radial, circumferential, and longitudinal directions. From this figure, we can find that left ventricle longitudinal peak diastolic strain rate showed correlations with LA reservoir in the figure A and figure B, and the LA conduit functions in the figure C and figure D parameters. In conclusion, this CMR feature tracking technique could detect early left ventral diastolic dysfunction in hypertensive patients with or without left ventricle hypertrophy. Early left ventral diastolic dysfunction in hypertension patients might be associated with left ventricle reservoir and conduit dysfunction. Thank you.
So, due to the absence of the Dr. Yan Song today, so we move to the next presentation. Please, Dr. Pandelakis, present.
Yeah, thank you. So the next presentation is from Bayan Chuang. The title is Left Ventricular Strain Can Predict Outcomes of Pulmonary valve replacement in patients with impaired tetralogy of Fallot. Bayan Chuang from China, please.
I'm honored to share my research with you at this great meeting. My name is Diane Gong from the Peking University Wuhan Hospital. My topic today is left ventricular strain can predict outcomes of pulmonary valve replacement in patients with retired tetralogy of Fallot. As we know, tetralogy of Fallot is the most common type of congenital heart disease. A lot of people are treated with top repairment. However, pulmonary regurgitation is commonly occur after retired top and lead to poor prognosis. Thus, pulmonary valve replacement (PVR) is introduced to reduce the late complications. Nonetheless, although more and more literatures have reported PVR as the treatment of severe pulmonary regurgitation after retired top, effects of PVR on ventricular remodeling is still controversial. The recovery of right ventricle function is after successful PVR is inconsistent. Compared with the traditional measurements of ventricular function and volume, the myocardial strain detected by CMR phase tracking has added value to predict outcomes in a variety of cardiovascular disease. Due to ventricular coupling, the left ventricle strain is also implicated when the right ventricle volume overload. So the left ventricle strain has potential to provide valuable information before PVR. So our study aims to analyze whether pre-PVR left ventricle strain and strain rate detected by cardiac magnetic resonance imaging (CMR) are associated with long-term outcomes after PVR in patients with retired TOF. This picture displays the post-processing method of strain and strain rate. The epicardial and endocardial borders, excluding papillary muscles and trabeculae at the end-diastole, were semi-manually defined in short-axis and long-axis images to calculate strain and strain rate. We have collected patients from 2040 to 2090 and included asymptomatic patients with moderate to severe pulmonary valve regurgitation post-retired TOF who meet at least two of the following conditions. And the following exclusion criteria were also established, including obvious symptoms occurred: severe right ventricle outflow tract obstruction, right ventricle pressure surpass or equal to left ventricle pressure, ICD inserted or history of PVR, and contradictions for CMR or surgery and patients with incomplete or poor quality of CMR imaging. Adverse events in our study including death due to any causes, cardiac transplantation, application of ICD, heart failure, syncope, reoperation for PVR, substance atrial or ventricular arrhythmias, and cardiac catheterization were documented during follow-up. Now let's look at the result. In total, 45 patients were included for analysis with an average follow-up duration of 3.2 years, and 12 patients had noted adverse events. From this figure, we can see patients with noted adverse events had a lower absolute preoperative left ventricle radial strain, circumferential strain, longitudinal strain, and strain rate, systolic radial strain rate, early diastolic radial strain rate, and early diastolic longitudinal strain rate. However, there were no significant difference observed in left and right ventricle function parameters. Then the optimum cutoff value of PVR strain and strain rate were identified using a receiver operator characteristics curves analysis by using index. Then the area under the curve was calculated. We found that the areas under the curves of circumferential strain is the highest. This green line. After that, the KM survival curves verified that patients with significantly reduced radial strain, circumferential strain, longitudinal strain, strain rate, systolic radial strain rate, early diastolic radial strain rate, early diastolic longitudinal strain rate had worse event-free survival. After further univariate analysis and multivariable analysis, adjusting for age, sex, cardiovascular risk factors, and cardiac function parameters, the early diastolic longitudinal strain rate is the independent prognostic vector of adverse event. So we can draw to the conclusion that conventional function parameters of both ventricles were not able to predict outcomes of PVR in patients with retired TOF, and the preoperative left ventricle radial strain, circumferential strain, longitudinal strain, and systolic radial strain rate, early diastolic radial strain rate, early diastolic longitudinal strain rate was significantly associated with adverse outcomes after PVR surgery in retired top patients. And patients with the highest incidence of adverse events were those with a severe reduction in left ventricle early diastolic longitudinal strain rate before PVR surgery. Our study had some limitations. First, we had a relatively small sample size and the number of heart events was small. Last, since we only provide the strain and strain rate data of Circle CVS software, the data of other vendors still need to be further supplemented by other studies. This is the end of my presentation. Thank you for listening.
Okay, thank you, Dr. Bayan Chuang. So next will be chair from Dr. Nguyen, please.
Okay. Next speaker, I would like to introduce Dr. Phung Bảo Ngọc, my colleague in our hospital. She specializes in cardiovascular imaging, and now he has present topic evaluation of myocardial injury on cardiac MRI in patients with reperfusion after acute MRI. Please, Dr. Ngọc.
Good afternoon, Chairman. Good afternoon, ladies and gentlemen. Today I present a small study in my hospital last year, evaluation of myocardial injury on cardiac monitoring regional imaging in patients with reperfusion after acute myocardial infarction. Acute myocardial infarction is necrosis of an area of the myocardium after a sudden and or prolonged myocardial ischemia due to obstruction of one or more coronary arteries. In the United States, every 40 seconds has one MI case, and about 800 million cases per year. The prognosis of patients after acute MI is strongly dependent on the extent of myocardial necrosis. Many studies have shown that the size of myocardial necrosis after MI is closely related to the survival rate and subsequent cardiovascular events. Cardiac MRI with more advanced technique is widely used as a non-invasive method for assessing cardiac morphology and function in clinical practice. While blood CT scan is considered as a standard reference method in evaluating cardiac function and regional dyskinesia, especially in acute MI with LV deformation. Delay contrast enhanced second can evaluate myocardial necrosis region, especially small or subendocardial infarction of posterior and inferior LV. Determine the compatibility between DE area and infarct-related artery. Accuracy about 93 to 99%. So can identify the coronary need intervention in the case of multivessel CAD. Assess thromboembolic infarction extension and necrotic sign, so can prognosis for LV function improvement post revascularization. This study has two objectives. The first, evaluate DE characteristics in patients with acute MI and accuracy of cardiac MRI for identifying MI location. The second, assess the correlation between necrotizing myocardial size on DE second and LV systolic function. Material and method. From April 2030 to November 2019, we have 15 patients, mean age 59 years, 40 males, suffering from acute MI underwent cardiac MRI within 9 days after percutaneous coronary revascularization. Using a 1.5 Tesla MRI machine, the protocol included single-wide blood sequence, the delay contrast enhanced on short and long axis, 2 chambers and 4 chambers. We analyzed LVESV, EDV, and EF. Delay contrast enhanced area and score. The infarct size was measured by planimetry and scoring method. Perpetrator coronary on CCA was independently determined by interventional cardiologists. Here are our results. The first purpose characteristic of contract enhanced on delay enhanced MRI. You can see 98% of patients present delay contract enhanced on MRI. 6% had two delay enhanced area. 76% had transmural delay enhancement, and 62% presented microvascular obstruction. So cardiac MRI had high sensitivity in identifying infarct area with delay enhanced. Similar to Raymond Kim study, 99%. The agreement between the result of delay enhanced MRI with perpetrator coronary lesion and percutaneous coronary revascularization for all patients was 90%. And for STEMI patient was higher with 95.6%. So cardiac MRI had high diagnostic accuracy for identifying MI location. Our study had a lower level of position diagnostic appropriateness than that of Raymond Kim, 98%. Possibly, we selected patients with single and multi-vessel CAG, in which Raymond Kim only evaluated patients with single vessel coronary artery disease. The presence of a multiple location region can lead to multiple infarction areas on the same patient, leading to inconsistencies between MRI result and CCA. Among STEMI patients, our results similar to the study of Karen E. Harmo, with 96% diagnostic relevance. The second purpose, comparison of necrosis myocardial sign on the MRI between planimetry method and scoring method. Correlation between necrosis myocardial sign and LVEF. The infarct sign measured by scoring method was 30.8%. Planimetry method was 29.9%. The difference between the two methods was 0.9%. There was an excellent correlation between a quantitative planimetry and scoring method for the measure infarct size, with R in 0.975 and P less than 0.0001, similar to Azevedo Fajo, with R is 0.94 and P less than 0.0001. So the scoring method can be used as an alternative to the planimetry method to evaluate the infarct size due to its simplicity, quick measurement, and high accuracy. We can see a negative and good correlation between infarct size and left ventricular EF on significant at the same time with the Simpson method. Similar to other authors, our study showed a good correlation between infarct size and LVEF in patients after acute MI. The infarct size is larger, the left ventricular EF is worse. Conclusion: the sensitivity of the second for detecting MI was 98%. The accuracy of MRI for identifying MI location was 90% with all patients and was 95.6% with STEMI. An excellent correlation between two methods for the measure infarct size. A negative and good correlation between infarct size and LVEF in patients after acute MI. So the cardiac MRI is feasible for the evaluation of myocardial injury in patients with reperfusion acute myocardial infarction. My presentation is end. Thank you for your attention.
Okay. So thank you, Dr. Ngọc, for the nice presentation. Any comment or question from the audience? So now we move to the next topic. Is Professor Dr. Pandelakis.
Thank you, Dr. Nguyen. So the next speaker is Dr. Di Chou from China. The topic is cardiovascular magnetic resonance characteristic, gene variant, and clinical implication in the patient with left ventricular non-compaction cardiomyopathy. Please, Dr. Di Chou.
Hello everyone, my name is Zhou Di from Fuwai Hospital. It's my great honor to be here introducing my presentation about CMR characteristics, gene variants, and long-term outcome in patients with left ventricular non-compaction cardiomyopathy. LVNC is a genetically and clinically heterogeneous cardiomyopathy that can occur in isolation or in correlation with other congenital and acquired cardiac pathologies. It is characterized by a heavily hypertrabeculated myocardium communicating with the thin epicardial compact myocardium. The AHA classified LVNC as a genetic cardiomyopathy. However, the ESA has defined LVNC as an unclassified cardiomyopathy that does not take a firm stance on whether it is a separate cardiomyopathy or a morphological trait, and the results of studies regarding correlation between genotype and outcome are inconsistent. One of the key issues underpinning this controversy is the paucity of data confusing on evaluating cardiac structure and function in patients with or without gene mutation. Due to the wide spectrum of clinical manifestations in patients, there is no universal definition of the severity of LVNC by imaging methods, let alone the association between imaging performance and the genotype status. In this study, we aim to investigate the CMR characteristics and genotype CMR phenotype correlation in patients with LVNC and to explore prognostic information in this cohort if possible. Diagnosis of LVNC was referred to consensus of re-evaluated echocardiography and CMR imaging by experienced cardiologists and radiologists. Primary endpoint was a composite with all-cause death and heart transplantation. Study was performed on a 1.5T scanner and post-processing using software Argus and MEDIS. This is the CMR protocol of our study. The extent of non-compact and compact myocardium, as well as the ratio, were measured on the four-chamber long axis geometry. LV mass index were measured based on the short axis cine images. Note that papillary muscles were excluded from LV mass, but included in LV and diastolic volume and systolic volume. Left ventricular and atrial string analysis were performed offline using a commercially software QString MEDIS. A total of 28 LVNC patients were included in the current study. 17 pathogenic variants were found in 11 of patients, of which 10 of variants were located in sarcoma genes. There were no differences in clinical baseline characteristics between positive genotype and negative genotype groups. Participants had significantly lower left ventricular ejection fraction and indexed stroke volume, as well as greater LV volume. Impaired left ventricular and atrial string were observed in all of subjects, but a partial of patients did not show significant enlargement of left atrial. Correlation analysis revealed that LV and diastolic volume index were strongly associated with indexed left ventricular mass. LV global deformations were associated with CMR parameters regarding the non-compact and compact areas, whereas not of left atrial parameters derived from CMR feature tracking. There was no significant differences between positive genotype patients and negative genotype patients in the LV volumetric and the morphological parameters. Low LV ejection fraction, cardiac index and a larger percentage of LGE were observed in carriers of multiple variants compared to non-carriers. CMR feature tracking analysis detected significantly increased left atrial volume in the positive genotype groups. Compared to negative genotype patients, carriers of multiple variants was associated with reduced LV global circumferential strain, increased left atrial volume, reduced left atrial strain and injection, corresponding to reservoir and contractile function. Using ROC analysis, left atrial volume was able to discriminate patients with positive genotype and strongly predict carriers of multiple variants in this cohort. During a median follow-up of 5.1 years, left atrial volume, LV global strain, ejection fraction, and the percentage of LGE strongly predict primary endpoint. Kaplan-Meier survival analysis revealed worse primary endpoint-free survival among carriers of multiple variants. In this heterogeneous cardiomyopathy, LV systolic dysfunction, LV fibrosis, left atrial enlargement and dysfunction, and risk of adverse events were linked to genetics to some extent. Left atrial volume was strongly able to discriminate patients with positive genotype and carriers of multiple variants from negative genotype. CMR metrics provided important prognostic information in patients with LVNC, whereas the complicated association between genetics and long-term outcome need to be explored in larger cohort further. In conclusion, cardiac involvement assessed by CMR presentation is associated with genetic status in patients with LVNC, especially influenced by multiple genetic mutations interacting. Left atrial volume is a sensitive and robust indicator of genetic mutational condition, of which facilitates to guide clinical management and intensity of follow-up for patients and their relatives. CMR feature tracking is a remarkable tool to evaluate implication, genetics screening, cascade screening, and provide prognostic information in LVC population. That's all. Thank you.
Thank you, Dr. Jody. So the next presentation will be introduced with Dr. Nguyen.
Okay, thank you. Next speaker, I would like to introduce Dr. Jeong Hyun Kim. He's from Seoul National University, Korea, with topic circumferential transmural strain difference in patients with apical hypertrophy cardiomyopathy. Assessment with feature tracking CMR. Please.
Good evening. I am a junior student from Seoul National University College of Medicine. Today, I'll brief you on my research left ventricular strain in apical hypertrophic cardiomyopathy, assessment with cardiac MR feature tracking. Before I begin, I would like to thank Sang-il Choi, Associate Professor of Seoul National University Bundang Hospital, for advising my research. Hypertrophic cardiomyopathy, HCM, is the most common genetic cardiomyopathy with a prevalence of 1 in 500 people. It is thought to be a leading cause of sudden cardiac death in the young. HCM has been conventionally diagnosed by echocardiography or MRI, evaluating maximal alveolar thickness. However, there are some limitations such as difficulty in differentiating similar phenotypic disease and poor ability to detect the early disease state. To overcome these problems, strain is recently suggested to be a more sensitive marker for evaluating cardiac dysfunction, including HCM. Strain reflects the change in length normalized to the original length. Very recently, the circumferential transmural strain difference, that is the difference between epicardial circumferential strain and endocardial circumferential strain, is suggested to be a newly sensitive marker for evaluating cardiac dysfunction. In 2019, Wigner suggested that the circumferential TSD is elevated not only in overt HCM, but also in preclinical HCM compared to control group. However, it is hard to accept the conclusion straightforwardly to Asian people because over 90% of HCM is accepted type in Western population. Otherwise, apical type is relatively common in Asian population, affecting up to 30%. Because there is no data in evaluating apical HCM and the LV apical wall is hardly evaluated by cardiac echography, there was a need for the study of a strain assessment in apical HCM cohort by MR picture tracking. The purpose of this study was to evaluate strain, including circumferential TSD in apical HCM by cardiac MR picture tracking, and to explore the correlations between circumferential TSD and other markers of the disease status. The study was a retrospective single-center study. Total 29 participants who underwent cardiac MRI from 2009 October to 2020 October were participated. 17 apical HCM group and 12 normal group were included. MR images were analyzed by the software Suite manually. We obtained LV strain from CINE MRI and segmental rate gadolinium enhancement volume from DMRI. Strain between groups were compared by Mann-Whitney U test. The correlations between circumferential TSD and other markers were analyzed by Spearman's rank correlations test. This is the example of image analysis. We traced epicardial contour, that is green line, and endocardial contour, that is red line, at end diastole and end systole phase from each CINE images. And then the program automatically tracked the LV myocardial motion during the entire cardiac cycle and calculated the LV strain values. This is the example of rate gadolinium enhancement volume analysis from DMRI. We traced each contour and designated region of interest. Then the rate gadolinium enhancement volume percentage for each segment were suggested as full-size image. Now I'll show you the results. Table 1 suggests the demographic characteristics of the study population. The number of hypertension and smoker were significantly higher in apical HCM group. At MR parameters, ejection fraction, stroke volume cardiac output, LV mass, indexed LV mass, and indexed LVED volume were significantly higher in apical HCM group. Circumferential strain and circumferential TSD results are presented in Table 3. Compared to normal group, average circumferential TSD and segmental circumferential TSD of base, mid, and apex were significantly higher in apical HCM group. The mean difference was greatest at apex at 15. Epicardial circumferential strain was significantly less in apical HCM group than normal group at average and apex. However, the endocardial circumferential strain was significantly greater in apical HCM group in mid, apex, and average. There were no significant results in longitudinal and radial strain. There was a moderate correlation between global circumferential TSD and indexed LV mass with correlation coefficient 0.574 and p-value 0.002. There was a weak correlation between segmental circumferential TSD and segmental LG percentage of LV volume with correlation coefficient 0.238 and p-value 0.001. The main point of this study is that segmental circumferential TSD of apex was significantly higher in apical HCM. It means that increased circumferential TSD reflects systolic dysfunction caused by myocardial fibrosis, subendocardial dysfunction, or myocyte disarray. However, interestingly, we found that the segmental circumferential TSD was also higher in apical HCM at base and mid segments. We thought that it is due to underlying disarray or fibrosis in segments without marked thickening. This also implies that systolic dysfunction could be detected by circumferential TSD evaluation in the absence of increased LV wall thickness. There were weak to moderate correlations between circumferential TSD and other markers for apical HCM. Overall, by this study, we speculate that string analysis by cardiac MR feature tracking would provide a lot of clinical benefits for apical HCM, because it does not need an additional image unlike CMR tagging, and it could detect the early stage of apical HCM unlike conventional imaging modalities. Therefore, we concluded that cardiac MR feature tracking identifies myocardial dysfunction well in apical HCM, and the circumferential TSD would be a useful imaging biomarker for early detection of apical HCM. Thank you for your attention.
So, okay, due to the absence of Dr. Kim, the presenter Dr. Kim, and also the advisor, the Professor Sang-In Choi, so we move to the next presenter. Please, Dr. Zakos, present.
Thank you, Dr. Nguyen. So the next speaker is Dr. Akio Inage from Japan. The title is, the topic is Usefulness of Non-Contrast Enhanced Angiography for Congenital Heart Disease by SSAP Radial Scan. Dr. Akio Inage, please.
Yep. Please start. Report on usefulness of non-contrast angiography for congenital heart disease by SSAP Radial Scan. We don't have COI. With the improvement of the performance of the MRI apparatus, it has become possible to performance various non-contrast special image. Even in the pediatric area, that's using ECG gating and whole heart imaging using ECG gating and respiratory synchronization. In recent years, it has become possible to perform imaging under free breathing using radial sampling without ECG gating. This time, we report the usefulness in congenital heart disease by steady-state free precession SSSP using radial sampling. This is the newest non-contrast angiography, radial SSSP. The characteristic is sequenced with SSP using non-ECG gating imaging and free breathing using radial sampling. The 1.5 Tesla SSP provides high intertissue contrast and enables simultaneous imaging of arteries and veins. It can be imaged in a short time of 3 to 5 minutes. We can also create maximum intensity projection, multiplanar reconstruction, and 3D volume rendering technique. The disadvantage is inability to separate arteries and veins, susceptible to metal artifact. On the left side is a traditional wall heart SSP. The radial SSP on the right side has higher intertissue contrast and is superior in morphological evaluation of congenital heart disease in a short time. Siemens magneton solar 1.5 Tesla was introduced to the Sakakibara Heart Institute from April 2019, and the radial SSP was imaged for about 200 patients, and its usefulness for cardiac morphologic evaluation is verified. This is imaging acquisition at our institute. The mean age of 213 cases was 26 years. Diagnosis was mainly in 130 cases of congenital right heart disease, such as tetralogy Fallot, 45 cases of Fontan circulation, such as hypoplastic left heart syndrome and tricuspid atresia, and 38 cases of congenital left heart disease, such as transposition of the great arteries and aortic valve disease. We will present some cases. A 25 years old larger SSP and 3D VRT image of repaired tetralogy follow. The enlarged right ventricle, right and left pulmonary arteries, and pulmonary veins were clearly visualized, and 3D VRT was able to evaluate the right ventricular outflow tract and right and left pulmonary arteries in more detail. Next case is 44 years old tricuspid atresia, radial SSP after Hontan procedure TCPC, and its 3D VRT image. The Hontan circulation from the superior vena cava to the right and left pulmonary arteries, and from the inferior vena cava to both pulmonary arteries via conduit was clearly visualized. In the same case, the right side is the MIP image. The maximum intensity projection clearly visualized the blood vessel wall in both the arteries and veins. Next case is a 33 years old case of complex cardiac malformation, mitral atresia, double aortic right ventricle, pulmonary atresia, bilateral superior vena cava, inferior vena cava interruption, hemorrhagic connection, and total pulmonary shunt with hepatic inclusion. Bilateral superior vena cava, hemorrhagic connection, and total pulmonary shunt with hepatic inclusion, shown in blue, were clearly imaged. Next case is the 20 years old complete transposition of the great artery. Status post arterial CT operation. It is an MPR image. The cross-sectional image showed the positional relationship of the great arteries and stenosis of the left pulmonary artery due to the exclusion of the ascending aorta was suspected. It is a 3D VRT image of the same case. The left pulmonary artery stenosis was clearly visualized. It is the same case. Radial sampling can be reconstructed in the coronal, axial, and sagittal directions as well. The radial SSP was possible to especially clearly delineate the blood vessels, such as the superior vena cava, inferior vena cava, and the pulmonary veins, which were difficult to delineate using conventional non-contrast imaging. In addition, MIP and MPR processing and VRT creation were also possible after imaging and were useful when conducting case studies and patient explanations. This is a discussion about radial SSP, even though it is 1.5 Tesla. There is signal unevenness in the plane because it is susceptible to uneven magnetic field. Also, intertissue contrast is high. It is susceptible to flow artifact due to turbulence such as accelerated blood flow and where multiple blood vessels intersect. Stent, valves, wires, coils are highly susceptible to metal artifact. These were cases affected by artifact. The left side is artifact due to sternum wire. The center is a flow artifact due to venous blood flow. And the right side is a flow artifact due to accelerated blood flow due to pulmonary artery stenosis. In conclusion, non-enhanced radial SSP was able to image blood vessels with mixed arteries and veins, such as Fontan circulation in congenital heart disease. However, there are also occasions where it is necessary to rely on contrast imaging for delineating detail. Further case studies is needed in the future. Thank you for your attention.
Thank you, Dr. Akio Inage.
Yep.
Nice presentation and video. So we open for discussion. Is there any question?
Yeah, I have a question with
Please.
for Dr. Akio Inage.
Yep.
Yeah. In your presentation. You talk about the radio steady state precision technique, and I have a question. The patient need the breath hold or free breathing. Can you explain more? And how long? How long for the sequence? Can you come?
It's just only up to 5 minutes.
After 5 minutes?
Yeah.
And the patient free breathing or need breath hold?
Sorry?
The patient need breathe, hold breath or free breathing?
The free breathing.
Free breathing?
Yeah.
Okay. Oh, thank you.
Thank you.
Thank you, Dr. Nguyen. I have one question also for Dr. Akio Inage.
Yep.
There is an artifact, like a metallic artifact. Do you exclude the patient, or you still have special reconstruction image if there is an artifact, metal artifact?
Yeah, if there's some artifacts that at the time that we selected another sequences, usually I select the radial gradient sequence. Yeah, it's some tissue contrast is lower than radial SSP, but for artifact is I think it's better. Okay. The radial gradient is better, I think. Yeah.
Thank you very much. So, Dr. Nguyen, please, for the last speaker.
Okay.
Introduce.
Yeah, thank you. The last speaker, I would like to introduce Dr. Ellen. Can you show the slide? She is a cardiologist. She works in Department of Cardiology and Vascular Medicine, University Indonesia, with topic the role of cardiovascular magnetic resonance imaging in the diagnosis of arrhythmogenic right ventricular cardiomyopathy. Please, Dr. Ellen.
Thank you for the opportunity given to me. I'm Ellen from Jakarta, Indonesia. In this session, I will present a case. Let me share screen first. I would like to present a case titled The Role of Cardiovascular Magnetic Resonance Imaging in the Diagnosis of Arrhythmogenic Right Ventricular Cardiomyopathy. Introduction. Arrhythmogenic right ventricular cardiomyopathy is an inherited cardiomyopathy that can lead to sudden cardiac death and heart failure. RVC is present in up to 20% of individuals who experience sudden cardiac death. Cardiovascular magnetic resonance, or CMR, with its high spatial resolution and tomographic imaging capability, helps to confirm the diagnosis of RVC. Clinical report. A 42-year-old man presented with a complaint of palpitation and syncope. Ventricular tachycardia documented with left bundle branch block with superior axis was originated from apical right ventricle. Resting electrocardiography showed us epsilon wave here in leads V1 and V2, and inverted T waves at leads V2 to V6. Cardiography revealed RV hyperkinetic with decreased systolic function. We can see here dilated RV with dilated RVOT diameter of 42 mm by parasternal short axis and 58 mm by parasternal long axis view. From CMR, in cine images, we can see here the volume of left ventricle is still in normal limits, with ejection fraction is mildly decreased, 52%, and right ventricular end-diastolic volume index was dilated 172 milliliter per meter square, and ejection fraction was decreased 30% for right ventricular. And the motion is kinetic at basal septal, and then akinetic at apex, basal RV, hypokinetic at other part of RV. We found fat infiltration at septal RV outflow tract, interventricular septal, and apical left ventricular and right ventricular junction. It appears as hyperintense area at T1 with black blood image, and then hypointense or suppressed by fat suppression T1 spectral presaturation with inversion recovery. We can see fat infiltration here, bright or hyper intensity things here, and suppress here, bright fat here, suppressed fat here, this also, and this, and also this and this. From left gadolinium images, we found epicardial LGE at basal to apico-inferior and mid to apicolateral segments. And we also found intramyocardial LGE at basal mid anteroseptal of left ventricular. The LGE mass was 21.5 gram, or LGE volume is about 27.8%. We diagnosed this patient with arrhythmogenic right ventricular cardiomyopathy. It fulfilled more than two major criteria of 2010 revised task force. And then this patient with a history of syncope and sustained VT, so it's indicated to insert an implantable cardioverter defibrillator. As notes here, the location of this fibrofatty infiltration was associated with the origin of ventricular arrhythmia. Discussion. RVC, or arrhythmogenic cardiomyopathy, is a progressive heart muscle disorder characterized by ventricular arrhythmia, heart failure, and sudden cardiac death. The histological hallmark of the disease is replacement of cardiomyocytes by adipose and fibrous tissue. Clinically, RVC is defined by structural and functional abnormalities of the right ventricle, but LV involvement occurs in more than 50% of patients. In the task force criteria 2010, the major criteria from MRI is RV regional wall motion abnormality qualitatively, and reduced RV function or RV ejection fraction, and dilatation of RV quantitatively. Meanwhile, fat infiltration and LG have not been included in the difficulties to access them at thin right ventricle wall. Fat infiltration is an additional feature that may confirm the diagnosis when contractile dysfunction and dilated RV are found. The LG area in RVC has had excellent correlation with histological findings and inducible ventricular arrhythmias by electrical stimulation. In the proposed Padua criteria, released in 2020, LV involvement has been considered as a late-stage manifestation of this disease. However, it has recently been brought into question with cases evidencing LV involvement only as a new term as arrhythmogenic cardiomyopathy. In the proposed Padua criteria, this disease has been defined as a genetic heart muscle disease which affects the RV only, LV only, or both. And LGA profile has been included in the structural myocardial abnormalities criteria. This is the criteria. This is the upgraded version of the right ventricle and a new diagnostic term for left ventricle. Yeah, we can see here the LGE appearance has already been included. This case was categorized as arrhythmogenic cardiomyopathy with biventricular disease based on this criteria, and with a history of sustained VT that not hemodynamically tolerated. This patient had indication for ICD insertion. As summary, we reported a case of RVC with LV involvement that meet major criteria for MRI together with fibropathy infiltration identification. Thank you. Greeting from Jakarta.
Okay, so thank you for your nice presentation, Dr. Ellen. So any question or comment from audience with the present? Yeah, I have a question for Dr. Ellen. And what do you think about the frequent of the ARVC in your country or in your center? It's a common or it's rare disease? Can you open?
Dr. Ellen, your mic still closed. Mute.
Okay, yeah, I'm sorry. Thank you for the question, Dr. Nguyen. Yeah, usually we receive the referral from the electrophysiologist from arrhythmia division, presentation with arrhythmia clinical manifestation. So far, we already confirm the diagnosis of RVC. Maybe it's about 5 cases for these latest 4 years, I think. Confirm from the criteria, the ECG, the RV profile, RV dimension, or RV ejection fraction, and also the biopsy.
Okay, thank you. So, any question or comment from the audience with the speaker? Dr. Zakus, do you have any comment or?
Yeah, thank you, Dr. Nguyen. Yeah, all of speaker already present. I'm very appreciate even this very difficult situation. Yeah, I think thank you very much for all of you and also Dr. Nguyen.
Okay. So if there are no questions or comment, I would like to announce the closing of this afternoon session. Thank you all the speaker, participant, and our co-chairman, Dr. Zakus Panelakis. Thank you.
Yeah, thank you. See you
okay,
then.
Thank you. Bye-bye.
Bye.
Bye.
One day, we can all stay healthy, and no one suffers from hunger. We will only realize this vision together. Together, we will come back stronger. Together, for a future with health for all, hunger for none.
My journey continues, and I know I'm not alone. Because together, we can make a difference every day.